Okay, good morning, everybody. It is Thursday, October 13th, 2022. Our presenter today is Emily Heerman from the transplant surgery team. So please give your undivided attention. If you are on Zoom, it looks like everybody's on mute, but just be aware of that. So we don't have any background noise. If you guys can't hear us or can't see the screen, throw it in the chat. We'll try to check that as well. Got that recorded. Okay, they should be able to see that. Great. Okay.
Is everybody comfortable? I take my mask down just to speak?
Definitely,
Okay,
yeah.
great. It's just a little easier to see
course.
on a Zoom and everything. Hi, guys. Thanks so much for having me. I'm Emily. I'm a nurse practitioner with Transplant Surgery, and I'm here to talk to you guys briefly just about transplant. My goal is to talk mostly about kidney, but you guys get our donors and then also occasionally pancreas transplant. So I'm going to try to be quick and get you guys some 10,000 foot view and then stuff that's pertinent to you as well. So as I mentioned today, we're going to explore nationally transplant, also at Michigan Medicine. What is the current state? Give you an overview of transplant in all phases of care, including OR and post-op, discuss the care of living donors across all phases, and then just some brief pearls about pancreas transplant. So here's just a state of the state of patients in transplant nationally. So you can see here some metrics. I think it's really important just to sort of set the stage and give a frame of reference for, the breadth of this problem for patients. So there was in 2022, a total of 28,178 transplants performed so far this year. And you can sort of see people, over 100,000 people need organ transplants. And so it's a huge problem, and this isn't a problem that's going away anytime soon. Here at Michigan Medicine, we performed the first kidney in 1964 with over 5,400 performed total, and then first pancreas in 1984 and over 400 performed. So we've been doing this a long time here, but there's always evolving technologies and skills and patient populations. So it's important to know that, in terms of the whole scope of surgery and medicine, we're a fairly new field in a lot of ways. So here at Michigan Medicine, we have 729 people on the wait list. This is for kidney alone. So 729 on the wait list for kidney alone, 388 patients joined the list. So not only is our team managing patients in the perioperative phases, we also have the transplant nephrologists and surgeons that are listing patients. So we're responsible for actively listing and managing patients on the wait list. And then you can see here too that 341 patients were removed from the wait list. So we add some, we also have to take some away. Usually they're receive a transplant. So 220 received a transplant, some died, some deteriorated or have other reasons for being on hold. So last year in 2021, we did 222 kidney transplants. 54 came from living donors, 168 from deceased donors. So you can see that we have far more weighted in the deceased donor category. We love living donors. They tend to work well right away, and we'll talk about that. But you can see that it still is a difficult thing to get folks to bring a donor with them and find a living donor. So there's a huge need there that's ongoing. So we'll get right into it. So why do people get kidney transplants? Primarily diabetes. So these are indications at Michigan Medicine. So diabetes is the first reason, other glomerular diseases, hypertension, and then the remaining are sort of an array of different conditions that patients can have. Patients can have more than these, right? So they can be diabetic and hypertensive. And so a biopsy pre-transplant will be the true way to figure out why you have kidney disease. But I think this is important to note because these are the other conditions we have to co-manage, right? A diabetic may be on an insulin drip in the PACU if they're type 1 diabetic. So it's really, I think it helps set the stage for, diabetic, hypertensive patients have coronary disease, have, other needs that are going to need to be met possibly in your area. What's the journey like? So a patient's diagnosed with kidney disease. That can be in an early stage, right? Stage 2, stage 3, they're maintained by their primary, but then they sort of start to deteriorate. Then they're diagnosed with end-stage kidney disease. So typically that means a GFR dropping below 20 or starting dialysis. Then they get referred to our center for transplant. They come to an evaluation clinic where they're seen by multiple disciplines. They see a surgeon, a nephrologist, a dietitian, a social worker. They do an extensive workup. They're brought forth to a committee where the committee determines if a patient is suitable for transplant. Sometimes the committee decides a patient needs additional testing, workup, procedures, and then we decide if the patient can be actively listed. Then they await their transplant and then they get a transplant. There's a lot of different kinds of kidney transplant, even though we just talk about living donor and deceased donor. So in the living donor category, a living donor can be related to the individual. That would be a first-degree relative, like a child to a parent, or a sibling, that's a brother to a sister, direct blood, 100%. Unrelated would be folks that are more down the line, like a cousin. It could also mean a stranger. It could mean a neighbor, a friend. So you can have directed donation where you directly donate to a recipient. Non-directed, where you are coming forward and don't know anybody that needs a kidney and you just want to be altruistic, we used to call it, and want to donate a kidney. We can also have paired donation in chains, and I'll show you a schematic with some pictures of what those mean. For deceased donors, the most important thing to remember is we can take donors that have brain death. So those patients are called the DBD, and those are donors that are declared brain dead by universally agreed upon metrics. A neurologist would come evaluate the patient and they have an absolute declaration of brain death. So we actually procure those organs with a beating heart. So if you remember, brain death means we can actually cut out your organs while your heart is still beating. Donation after cardiac death or circulatory death, DCD, is where we terminally extubate a patient in the operating room and then we procure the organs. And so that's a little bit different. The patient may have some irreversible brain damage, but not meet all criteria for total brain death, or may have some other irreversible condition that declares them not able to survive. And so that terminal extubation can lead to long, warm ischemic time. So a patient is extubated in an operating room. They may have a blood pressure that's low, right? A MAP below 60 for some period of time before they actually expire. And so that prolongs the warm ischemic time, or time where the blood is pumping from a heart, but just not well. And that can damage organs. Kidneys are really resilient to that. Typically 60 minutes up to 2 hours will take kidneys, but livers are not so resilient. So there is some time metrics based on the organ you want to procure. And then in weird instances, you can actually have directed deceased donation. If Susie dies and knows Bobby needs a kidney, Susie's family could say, hey, do I match Bobby, and give it to her even after she dies. That's very rare, but it is a thing. So with living donors, they are great quality. The wait time is less. So if you come to clinic and have a living donor, we can facilitate a transplant within several months if both of you are healthy and ready to go. These kidneys tend to last longer. The average time for a living donor is approximately 12 years, give or take. You know, you've seen on the news, oh, it's lasted 20 years, 30 years, so that can happen. But the average is around 12. They typically have immediate graft function. So when you're in the PACU managing these patients, you see pee in the bag right away. So they are cruising right along. The living donors, unless they have a bad technical complication or otherwise, tend to have this working graft right away. And again, these may be related or unrelated. So if we can emphasize that, you know, confidentiality for these patients is huge. The person in Bay 8 might not know Bay 9, they're a pair, but they don't know each other. And we have to maintain that confidentiality. So being very cautious about saying, oh, your donor's doing really great. They don't want to be known to their donor, and we have to respect that. So this would be an example of a paired donation. So you can see the color metrics. So donor 1 knows recipient 1, but they're not compatible either by blood type or antibodies or for some other reason. And then donor 2 and recipient 2 are also not compatible, but they're willing to swap kidneys with each other. So you might actually have 4 bays of patients here one day, bed 2, 3, 4, and 5. Nobody really knows each other, but they're matched in this national or local paired program. So again, keeping that confidentiality, knowing that, you know, they may not know each other. Even their family could be sitting next to each other in the waiting room, but just not know, and this is happening. A chain can happen as well with the living donor. So you can see a non-directed donor. So that's somebody that doesn't know anybody, comes forward and says, I would like to be a kidney donor. They donate to recipient 1, and you can see that this sort of starts a chain effect. So you can actually have one person impacting the ability to transplant multiple people. You hear these on the news too. It's pretty neat to see somebody that just comes forward and donates and can really change a lot of lives. Deceased donor transplant. So as we mentioned, there's various ways you can get those too. As we talked about the brain death and the circulatory death, those criteria sort of are demonstrated again here. The quality can vary. So, you know, there may be a young person that's 20 that has a gunshot wound to the head and dies and is in perfect condition, right? That's a really good quality kidney. It's likely to work right away. We'll also procure a kidney from somebody that might be a little bit older, maybe had a stroke and died with a terminal creatinine of 2. So that kidney may not work right away, right? So we have no reason to believe it won't work well eventually, but it may be more susceptible to not working perfectly right away. As we talked about, the difference between the brain death is brain death declared, and then the circulatory death is procuring after withdrawal in the operating room. So I think you'll probably hear those terms maybe in sign out, DBD, DCD. So kind of being familiar with those, that terminology. So we talked about, the immediate graft function, which is really great because living donors typically work well right away. So the immediate graft function means that the kidney is working, making urine and clearing electrolytes and other toxins. Slow graft function means that the kidney is a little bit slow to maybe drop the toxins or clear the creatinine, but maybe making a little bit of urine. And then delayed graft function is something you guys might hear about. This is a kidney that we may expect to not work. So you might hear in the PACU, hey, this is a donation after circulatory death. The patient doesn't make urine at baseline, and we don't really expect this kidney to make much urine. So that patient may need to go to dialysis, and that's delayed graft function. If a patient needs dialysis within 7 days of the kidney transplant, that's deemed delayed graft function. Our rate of DGF here is approximately 30 to 40%. So you can imagine of your deceased donors you're getting here in the PACU, 30% we expect to maybe not work perfectly right away. So we may be able to give you that information as we're kind of signing out, but that's somewhat expected for some population of patients. And so about 30% have DGF, and then only about 1% to go on to never function at all. So even though we have delayed graft function, within weeks to months, those kidneys almost always work. So the risk of primary non-function where a graft never functions is quite low. So what does it look like for pre-op? These donors come from the floor, come to pre-op, or they're admitted right to pre-op. So if it's kind of an expedited, you might, on the pre-op side, see people coming through fast. The living donors are always admitted to the pre-op. Their H&Ps are done ahead of time. So these pairs are more thoughtful because we have time for planning. They get a large bore IV, heparin, induction. So that's the thymoglobulin that you guys might hear, and we can talk about that later. They get electrolyte checks, some serologies, and a catheters placed. So what happens in the operation? So it's about 2 to 4 hours long. It's a lower pelvic or oblique curvilinear incision closed with Dermabond. The surgeon decides what side. Some like to put a right kidney on the right side. Some like to put a left kidney on the left side. We sew external iliacs for our vascular anastomosis. So for the most part, these are not intra-abdominal operations. The donor vein to recipient external iliac is sewn, then the artery to the external artery. And then of course we have to sew the urine, right? So we sew the ureter from the kidney to the bladder over a stent. So those patients get a double J stent implanted to help that anastomosis heal. They're always going to come out with a Foley. We want to decompress the urinary system as we let that anastomosis heal for a couple days. And they may have a JP or Blake drain. So larger patients with a lot of subcutaneous tissue, we cut through the lymphatics when we do this operation. We don't ligate all them out. We don't tie all them off. It's just hard. So, if we're worried about fluid buildup or other collections, we may place a drain, particularly in larger patients. PACU. So this is the relevant pieces to you guys as we've set the stage for what a transplant looks like. Bedside handoff is expected for all of our patients. So we instituted this after a near sentinel event several years ago, probably about 4 years ago now, before COVID. We expect it for all kidney transplant recipients. So our goal was to enhance communication between the individuals that are involved in the care and the case. So the surgeon representative, either the fellow that did the case or the resident, should be present. An STX APP or intern should be there, anesthesia, and then the bedside nurse. Our goal is for each discipline to really briefly sign out what happened during the case and the expectations. This is where you might hear things like, this is a DCD, we don't expect it to make urine right away. This is, they were a little bit oozy in the OR, please watch for bleeding. So these are the points where we want to communicate some of those key elements that are going to be pertinent to the care. The APP or intern gets a page from the resident in the operating room when they're near closure, and that's how we know to come down and hopefully be present for this. Sometimes it doesn't work perfectly, and there have been instances I know where sign out happens and we're not there. Ideally, all members are there whenever we can, within reason. So any changes in the patient's condition, you should notify us. So on-call APP or intern, we have a pager, but we also love secure chat. So we'll be listed as the first contact for secure chat. I don't know if you guys have rolled that out yet. When you do, we're really into secure chatting. And then of course the PACU resident is here too. We're a little bit of an odd service in that we want to be involved in a lot of the care going on. So if there's urgent things, extreme hypotension, extreme hypertension, uncontrolled pain, decompensation, of course, the PACU resident is your person. If you want to start doing things like giving Lasix or treating, hyperkalemia, it's good to notify STX so that we can work together with the PACU resident in a non-emergent situation, so we all are on the same page, again, about the expected function of the graft, the expected outcomes of what we want in the PACU. The parameters to contact us are in the orders, and they differ based on the organ type. So living donors, we want to be notified if the urine output is 50 or less, deceased donors 30 or less. So the parameter of what you notify us based on urine output is different based on living or deceased donor. Our goal is to come down twice to the PACU. So STX wants to hopefully get down here 2 times, once for the sign out, and then once in the middle of their PACU stay to make sure things are going smoothly, answer any questions. And then of course, please page us or secure chat us if you have any concerns. Here's just a screenshot of what those metrics look like. So you can see for the living donor, the urine output, I'll direct you sort of towards the middle of the screen. We want to be notified if it's less than 50 mLs out for an hour. And again, here to the middle of the screen for a deceased donor, less than 30. So I think it's just important to note that, we really do want to know about these metrics. So if you notice changes, please, note these expectations and then make us aware if these are different or outside of the ranges. Induction. So I know we touched on that briefly in the pre-op side. All patients are assessed if they need induction. Every patient gets high dose steroid in the operating room. Doesn't matter what, or liver, kidney, we give steroids, 500 milligrams IV. That should be finished before they come to you. So that's given, right when they get into the OR by anesthesia. We also have induction with a medication called thymoglobulin. This is a T-cell depleting immunoglobulin that we give our patients. It's 3 doses they receive. And if they meet criteria, they begin the first dose in the operating room. This is sort of an extended infusion, around 6 hours for the first dose. So it's likely going to still be hanging when they come out to you. I think the biggest message to send home is, some patients don't tolerate it well. So you can have reactions to it. Allergic reactions. It can also cause an inflammatory condition called cytokine storm, where patients can become, sort of unstable because of this drug infusing. So if we have any patient that's unstable in the PACU and is currently actively infusing thymo, almost always our first recommendation is going to be to hold the drug. It can be given extended infusion over time, and that'll be our first sort of knee-jerk reaction, is hold that thymo. So if it's hanging and we come to the bedside, you could just verbalize to us, hey, thymo's still going. And that will be one of our first things that we'll notify you to do in terms of intervention. They're given intra-op, then day 1 and day 2. Yep, so post-op day 1 on the floor and then day 2 on the floor.
The nurse will ask them the final end because they try to time with the next. I'm guessing they time.
Yes. Yeah, we try to time with the next dose. We don't want to give it too close together. So we want to kind of know that information so that we, have a complete picture of what happened. Yep, that's a great point. Vital sign frequency. So your blood pressure management is per your PACU protocol. Whatever guidelines are for a patient that's emerging from anesthesia, we defer to you. We do want to stat CBC, sodium, potassium, and a point of care glucose in most cases, particularly for diabetics. Sometimes we'll ask for a full basic, but that's rare. We normally don't want to monitor the creatinine that soon after. We just don't know what to do quite with that information, but the electrolytes we want to know about. The biggest message I can send home today, and I think one of the reasons I'm here, is to monitor urine output hourly. So we sort of live and die early on. Even if it's expected that this kidney might not make urine, it might surprise us, right, and start to pee. So we might come out and say, we don't expect this kidney to make much urine. We think it's going to have delayed graft function or slow graft function. Please still record that urine dump. So everybody's going to come out with a urimeter. If it's a bag without a urimeter, please swap it out and be dumping these urines hourly and documenting on the flow sheet. We have a lot of patients and we can't run down here every minute to check that. And so we rely on that flow sheet documentation hourly to help guide interventions. We check 1-to-1 replacement for 12 hours. So we might be on the floor monitoring several other kidney patients, and that's why we can't run down here every hour to check it. So we really are looking at that flow sheet. Remember, native urine is still made. So if a patient comes in and makes some urine on their dialysis still, just because they have urine in their urimeter doesn't mean it's the transplanted kidney making urine. So that also changes our mind and our decision making after or in the PACU. Is this native urine? Is it transplant urine? If they have 300 mLs out an hour, it's likely that it's the transplant, and some native, if it's a robust urine output. So that's important for us to keep in mind. Low urine output, please notify the provider on call based on those metrics in your order set. The first thing we do is typically flush the Foley. Is it kinked? Is there any obstruction from the catheter? You know, just a light flush with a TUMI is helpful just to know if it's obstructed. Our typical first line intervention for low urine output is a bolus, and then our second line intervention is a bolus and usually an ultrasound. Acute oliguria or anuria in a transplant that's new might mean a vascular thrombus. And so that's often why we're checking this ultrasound. Do they have a vascular problem that needs emergent take back to the operating room? The only way to fix that is emergent take back, right? So that's often why we're getting the ultrasound. Also to check for bleeding, if they have a low hemoglobin, do they have a blood collection that needs intervention and is causing problems? Again, we replaced the urine output 1-to-1. So you should be dumping the urine hourly anyway because of the protocol. So just making sure you're documenting what you're doing. So replacing that urine output 1-to-1 with half normal saline. The resident or fellow will set the first hour of urine output, right? Because they just came out of the operating room. Oftentimes the question is, what do I set my first hour rate at? The resident or fellow at the bedside handoff should be directing you as to what that first hour replacement should be. And then subsequent hours just go 1-to-1 based on the urine output. They also have a maintenance fluid hanging that's separate from the thymo if that's hanging, that's separate from the replacement if that's going or when that's going at 40. So we want a maintenance fluid at 40, plus the replacement, plus if they have thymo going, all of those things happening at once, okay? Electrolytes, our most common problem that you guys will see in the PACU is hyperkalemia. We want to know the anticipated graft function. I keep sending that message to you guys. You know, if it's expected to have sluggish graft function, maybe they came in a little on the high side for potassium. We may need to do something when they're in the PACU. We consider temporization. The only thing we don't really give is Paxlate. We typically do the dextrose, insulin, bicarb gluconate as our first line. We may give Lasix as well. You're like, well, hey, you're giving Lasix to somebody with a creatinine of 5. It's a pretty thoughtful conversation about if we think this kidney might respond to some Lasix and it may be helpful. Or they may need dialysis. We sometimes send patients right from PACU recovery up to dialysis if the graft is not working and they're hyperkalemic. Cardiovascular problems for you guys might see, you know, as I mentioned, these patients are hypertensive, diabetic. They have their share of coronary artery disease. It's typically stable and monitored before, but we're putting them under a lot of stress by giving them an operation, maybe giving them some hemodynamic instability or anemia. So, you know, they may have cardiac problems. And so, you know, we may come down and see some stress on the EKG or, you know, new depression, hypotension, hemodynamic problems. So we would rely on you guys to kind of communicate that if it's serious with the PACU resident and then our team as well. Pain management is per the PACU anesthesia folks. So we don't write for pain management post-op. We rely on you guys. We don't routinely use a PCA. All of our living donors get a TAP block. So that's kind of a nice touch. And in the future, hopefully the deceased donors may get those as well. I think the living donors get them because it's a more organized and scheduled operation. Kidney donation. Before I move on to donors, any questions about recipients? I can't see questions on the chat yet, so I'll refer back to those. But anybody in the house have questions on recipients? Cool. Kidney donors. So this is cool. This is a chain actually. So we talked about the chains. This is between Michigan, Henry Ford, and Beaumont. So we actually had a multi-system chain in Southeast Michigan. So this is a photo of those folks, which was really neat. They're donors and recipients. The donor journey. So they decide to donate. They're referred to our center. They come to a multidisciplinary eval clinic as well. They have pre-op testing. We want to see what their kidney function is like, their volumes of each kidney. Are they healthy enough to have an operation? Then they go to the committee for decision, become an active donor, and then come forward to donate. So all these things are kind of thought of. You know, if you see a patient, you're like, they don't seem like a good social candidate for a transplant, you know, like this doesn't seem normal. They've all been vetted really heavily. So that's, you know, something that was really thought about by a lot of folks before they came forward to either be a recipient or a donor. So they have a workup. We have some criteria at our center. They have to be at least 18, free of coercion, healthy. They get a lot of pre-op testing done. And then again, they may or may not know the recipient. So that confidentiality is key. They get a large IV. They have a required specimen that we draw in pre-op holding. They also get a catheter placed intra-op for their donation. This is what you might see in the PACU for your living donor nephrectomy. So we do a laparoscopic hand-assisted donor nephrectomy. So you'll have your port sites and then your midline abdominal incision where the kidney comes out of. Those are all closed with Dermabond. They don't have drains. I've never seen a donor with a drain. I guess never say never, but it's typically, you know, not an oozy thing for them. It's about 2 to 3 hours intra-op. Typically, we take the left kidney. The vessels just happen to be a little longer on that side. It's a little easier of an operation to mobilize. So we often take the left if we can. And they're in a lazy lateral decube for their positioning. So, you know, sometimes they have this referred pain from their insufflation. Sometimes it's just positioning, right? They're healthy people coming in. So they may have some complaints that, you know, they're a healthy person. So it can be quite painful for them. They have strong muscles, right? Not a lot of exposure to health problems. So they may experience more pain or discomfort during recovery. What's the PACU protocol for our donors? So vital signs per your protocol. Urine output should be maintained. So I realize we're taking a kidney out, but we really don't expect a huge drop in urine output. We give them 120 milliliters of maintenance fluid. And so sometimes they come in a little dry. They maybe run a little dry in the OR. Again, they're healthy folks. Sometimes they need 3 liters, 3.5 liters, but they only got 2.5 in the OR. So in the PACU, they may have some low urine output. Our first line for them is to get a fluid bolus. So you might see one of the APPs come down, assess the patient in the first hour, the urine output's only 20, and we want to give a 500 ml bolus. That would be a very standard thing to have happen. Again, we want to make sure their Foley's not kinked, they're not having a Foley problem, so you could gently flush that as well. In the PACU for donors, there's no routine labs obtained. So again, these are healthy individuals, unless you're told otherwise, no standard labs. And then of course, page us if you have any concerns about these patients. Again, pain management is per your protocols. These patients actually get NSAIDs. So you think like, hey, they donated a kidney, should they take NSAIDs? We actually give them a short course of Toradol inpatient and then some Motrin after to help reduce their need for narcotics and really control their pain. So it does seem odd, but we are okay with Toradol in the house. They get a dose usually in the OR actually. So often they get a dose when they're rolling out, typically 15 milligrams, and then they also get a tap block. So that block really kind of helps manage their pain as well. Some brief pearls. Any questions about donors? You guys see them quite a bit. Yeah, pretty healthy folks. So it makes kind of their PACU recovery straightforward. Pancreas transplant. We really are not doing a ton. So I just want to give you some pearls. You guys may not see them for a long time. We did about 5 last year. You know, many years ago, we were doing maybe 10, 15 a year, doing less. The vast majority of indication for pancreas transplant is type 1 diabetes. So at our center, it's only type 1 diabetics. Nationally, you may find a center doing a different protocol, but for us, all a type 1 diabetic. Again, we perform around 5 a year. You can have different types of pancreas transplant. SPK is a simultaneous pancreas and kidney, where they're getting a kidney and pancreas at the same time. A pancreas transplant alone, or a PTA, is a patient that's just coming in for a pancreas transplant. Or a pancreas after kidney, PAK. It means that they got a kidney transplant from some other donor, a living donor or a deceased donor, then they're coming forward to get a pancreas transplant from a deceased donor. So you can have organ transplants from different donors in this case at separate times. They're all from deceased donors, and right now we don't do DCD pancreas recovery. The pancreas can just be a more finicky organ, and so we don't like that warm ischemic time or that injury, so we only do them from brain death donors. So as you can imagine, the kidneys that you get when you get a brain dead donor for a pancreas, usually a younger, healthier person. So a lot of folks say, hey, I want to wait on the kidney pancreas list because not only can I get a pancreas for my diabetes, but the odds of me getting a pretty good kidney are kind of high because we don't take pancreas from these marginal donors. So that can be a benefit to these recipients. And then they all are going to have induction with thymoglobulin. So kidney patients have to meet specific criteria. All pancreas patients, regardless, receive thymoglobulin. It's typically a midline incision. If you're getting them simultaneously, the pancreas usually goes on the right, the kidney to the left. Remember, we have to enterically drain exocrine function of the pancreas. You can see here that there's a portion of the bowel hooked, attached to the donor pancreas that's then anastomosed to the recipient because they have pancreatic juices and secretions and exocrine function. It has to go somewhere. And then you can see here the transplanted kidney is done the standard transplant kidney fashion. So typically panc on the right due to just where the location of the anastomoses have to go, and then kidney on the left. Bedside handoff is expected for these patients. They may have the thymo still running. Again, the vital signs per your protocol. They may have an NG tube because we did a bowel anastomosis. These patients are likely to come out with an NG tube to low continuous suction. A lot of type 1s have gastroparesis, right? So not only did we do a bowel anastomosis, but they have an underlying condition that's going to make their bowel function slower. So that NG tube might stay for several days. So they're likely to have that for you in the PACU and just hook that right up for us. And then they may have low dose heparin. So pancreas vessels are finicky. They are prone to thrombosis. So we may have slippery heparin or non-protocolized heparin, maybe at 500 going in the PACU. So you'd be notified of that. Usually we started after on the floor, but if they're on heparin, you know, that's a potential thing. The biggest thing for pancreas is blood sugars. So the way we know it's working is blood sugar. Acute hyperglycemia is a problem for a pancreas transplant. So we live and die by hourly urine output for kidneys and hourly blood sugars for pancreas. So just like we want the urine for kidney to know its function, we need that hourly sugar check for pancreas to know its function. Don't give any insulin regardless of the blood sugar. If it's 500, you need to call somebody before you do any intervention. That's the first thing you should do, is call STX if it's high. Usually means it's thrombosed, and we would get an ultrasound. And then we may advise you to give an intervention, but don't give an intervention. Just say, don't go to your PACU and say the blood sugar is 300, I need a sliding scale or something. That would not be the appropriate intervention for the PANC. And then call us or page us if you have any questions. Our team, so we have a huge team of APPs. We have 7. This group of 6 has been here a long time. We just added a new member, Lauren. She comes from Northwestern Transplant, so she has a wealth of transplant knowledge already, and she's onboarding on our team right now. So if you see any one of us, you'll see we rotate all through inpatient. So any one of us will be on call during the hours of 6 a.m. and 4 p.m. So we're primarily coming down for those bedside sign-outs if the transplants are happening within that time frame. And so we're on call on the on-call pager. So these are the folks you'll be getting a hold of when you call us. Stop us in the hallway. We love to talk about transplant. We love to share our knowledge. We are, you know, always happy to talk about concerns for our patients, and, more than happy to address your needs. And then our faculty. So I'm sure you guys know a lot of these folks. Dr. Sonenday is our transplant center director. He also does liver transplant, does kidney transplant, but he sort of oversees everything. Dr. Sung is the surgical director of kidney PANC transplant. And then we have 2 medical directors. You may see a variety of them in the PACU as well. Again, please stop them, talk to them. They will answer any questions. They could be the ones operating on your patients, except the medical folks, but we're all on the same team, so we're here to help. And then if you have any questions, feel free to reach out, email, anything we can do to help, we're here. That was kind of a whirlwind. I'm going to hit escape and see if there's any chat. I don't see any questions in the chat. Any questions in the house?
Notice that in the last probably 9 months to a year, we're not really running saline as a maintenance anymore. We're just running D5-half.
Yeah.
Even with diabetic.
Yeah, I would say that's a style thing. Typically we take the dextrose out on the floor. So if they're hyperglycemic on the floor, that's often our first measure. Our standard fluid is D5-half. Even if they're diabetic, you may see that. And then, as we transition them to the floor and they remain hyperglycemic due to steroid exposure, we're stopping it there usually. So yeah, it really, all of us have a little different style. And so you may continue to see that. Yeah. Yep.
Second thing is, when we have a living donor, we're normally seeing, well, depending upon if they give mannitol intra, we're seeing anywhere from 700 to a liter an hour for the first couple of hours.
Yeah.
And then still 500 plus. I've seen two types of responses to that. Some, they will go 1-to-1 for the first hour or 2, and then, or go up to 500 cc's an hour. And then after that, they like drop it down to maybe 150 and just run a maintenance at 150, like trying to slow the kidney down.
Yes, that is possible. I would say the protocol says to cap at 500 because you're right. The more we give it, the more it's likely to make. They do get the mannitol intra-op, so you may get some response to that still the first several hours. I would say keep the cap at 500. And if you have other questions that are non-protocol, just call the APP on call. If you're like, they're making a liter, what's your thought on doing this or this? We're happy to engage in those discussions. We like to stick with the protocol at the outset. And then if we need to make adjustments based on an individual patient, then yes. Yep, but I would cap at 500 because the more you give it, the more likely it's going to make. And those are normally the living donors that make some baseline urine, right? Maybe they were on PD, and a lot of times PD patients don't burn out the output. It's not clearing, but they still pee 3 liters a day. And then you give them a living donor kidney and they're peeing a liter an hour. you know, and so the more we give it, the more it pees. So yeah, that's where that cap comes from. Yep. Good questions. I see one in the chat. Let me see if I can navigate to it here. Oh, good question. Do they always take the cath out? The PD cath. Oh, great. Thanks, Emily, for clarifying. We consent for possible PD cath removal on every PD patient. And we say possible because it's our goal to remove it. We will never use it for dialysis in the immediate post-op period. So those DGF or delayed graft function patients, if you're on PD, you always get an HD line placed if you need dialysis. We don't use it. And so we aim to take it out. In some instances, if they're having difficulties intra-op or some other reason they may not take it out, I would say we almost always do, but you may have the rare moment where it had to be left in for some reason, and then we just don't use it and we take it out as an outpatient if the kidney is working well. Yep. Cool. Anybody else on the line there with questions? Okay, awesome. Well, thanks for your time. If there's anything else that you need, please reach out, okay? Thanks so much.
Excellent.
So I know there's still folks on the chat. I'm going to stop recording. I'm not sure if Trisha had to step out. So I don't know if there's more for you guys to learn or talk about, but I'm going to step away. Thanks so much for coming.